This is the third webinar in the series of recent advances in the cardiothoracic anesthesia. And before we start this webinar, I congratulate all the Indians and all the humanity on the globe for the successful landing of Chandrayaan again, which just happened, I think, a couple of hours before the last webinar. So today we have three distinguished my colleagues, and they are going to talk about three very important clinical and practical utility scenarios. So my first presentation, may I request Dr. Scott, if you can just display your CV slide. So our first presenter is Dr. Scott MacKenzie. He was our ex-section head for last 16 years, and he developed the cardiac anesthesia program at the University of Manitoba. He is level 3 certified in the transthoracic echocardiography, and he works in the echo lab with the cardiology section, and also he works in the anesthesia. And he was mentor even for me when I got my first degree from the ASA. So he is a very distinguished speaker, and we always go to him for all the problems when we encounter in related to the TE or the transthoracic echocardiography. So Dr. Scott, please go ahead with your presentation.
Virendra, thank you very much for that introduction. I just wanted to say it's a real pleasure to be here with you all today. My topic is the echocardiographic evaluation of diastolic function. Is it really that confusing? Well, I think it is somewhat confusing for many of us when it comes to assessing diastolic function utilizing echocardiography. And although the most recent guidelines from 2016 are an improvement over the previous guidelines, it still seems to be a somewhat onerous task to follow the current algorithms. And I hope that by the end of this talk, you'll have a little bit more clarity on this topic. I have no relevant disclosures. So what we'll be talking about today is the definition of diastolic dysfunction and why it's important. We'll look at the prognostic indicators as well as the consequences and the impact of diastolic dysfunction. I'd like to spend a fair amount of time going over the current guidelines and the echo parameters that are used within those guidelines to grade diastolic dysfunction. And then we'll look at some case examples and apply the guidelines to come to a conclusion as to what these patients have with respect to diastolic dysfunction. And finally, I'll go over some special situations such as mitral valve disease and atrial fibrillation, common conditions that we encounter in our patients, but it can be challenging to assess diastolic function in those populations. But let's begin with an introductory case. And this was a 71-year-old female who was recently admitted to our emergency room with increasing shortness of breath. An echocardiogram was ordered, and on the requisition, they asked, what is this patient's ejection fraction, and does she have elevated filling pressures? And as I go through these next few slides, in your mind, I'd like you to try and decide what degree of diastolic dysfunction this patient has. So on the left-hand side of the screen, you can see a parasternal long axis view, and on the right-hand side of the screen, we've got an apical four-chamber view. And I think you can agree that left ventricular systolic function appears well preserved, but the patient does appear to have left ventricular hypertrophy. You can see that on the left-hand side of the screen, the mitral E to A ratio was 0.8 with an E-wave velocity of 90, and then the LA volume actually measured to be within normal limits. The E to E prime is shown here with both the lateral and medial E primes being measured. The E to E prime was 14 in this particular patient, and the TR velocity, as you can see here, was 2.6 meters per second. So based on that, how would you report this? Is this mild diastolic dysfunction? Is it normal? Is it pseudo-normal? Is it restrictive? Is it mild to moderate? Is it indeterminate? Grade 2, or we need more information? Well, later on, we're going to talk about reporting this particular echo, but as you can see, I put down a number of descriptors that are used to classify diastolic dysfunction, and I think this can be part of the confusion. Some of these terms I think we should stop using, and we need to make some adjustments certainly in what we put in our reports to describe diastolic dysfunction, because ultimately the referring physician really wants to know, does my patient have elevated left atrial pressure? So we'll talk about how the guidelines suggest grading diastolic dysfunction, and we'll get into this shortly. But what is diastolic dysfunction? Well, very simply, it's abnormal relaxation and increased stiffness of the ventricle that can result in elevated filling pressure. And we know that echo is the main imaging modality for assessing this. Its methodology is very extensively validated, including outcome prediction. And the evaluation of LV diastolic function has become an important component of every echo examination that we do. We use data that we get from the two-dimensional image and Doppler to draw conclusions regarding the relaxation and compliance properties of the ventricle that we can then use to estimate filling pressure. And the echo estimation of filling pressure has proved very useful in evaluating patients with dyspnea of unknown etiology, as well as those patients with heart failure and preserved ejection fraction, the so-called HFpEF population. And it's become increasingly accepted that echo-based estimates of filling pressure can be used for clinical decision-making on a day-to-day basis. Well, I can tell you that in the echo lab I work in, shortness of breath and heart failure are some of the most common things we see in our requisitions. So I think assessing diastolic dysfunction is very important, certainly as a cause of dyspnea in the HFpEF population, but the clinician wants to know, are the filling pressures elevated? And then what is the response to potential treatment for these patients in follow-up echoes? At present, over 70% of the patients with heart failure who are older than 65 years of age have a normal ejection fraction. And the incidence and prevalence of HFpEF has been growing by about 10% every 10 years relative to heart failure with reduced ejection fraction, or HFrEF. And this gap is expected to widen in the coming years owing to the aging of our population, as well as the prevalence of conditions associated with HFpEF, such as obesity, metabolic syndrome, and diabetes. So yes, I think it's very important that we provide an accurate assessment of diastolic function in these patients. Now, not surprisingly, in patients with HFpEF, morbidity and mortality rates are higher than in the general population. And the most common cause of death is cardiovascular. But what's interesting is that morbidity outcomes in HFrEF and HFpEF patients are similar. And this includes the rate and frequency for hospitalization for heart failure, their symptomatic status as measured by abnormalities in myocardial oxygen consumption, 6-minute walk distance, and other quality of life indicators. So patients with HFpEF have a morbidity burden that's equivalent to those with HFrEF. This is a study that was published in 2006 by Okura et al. And these are Kaplan-Meier plots of survival in patients who were admitted with heart failure, who had a normal EF on the left-hand side of the screen and a reduced EF on the right-hand side of the screen. And you can see that an E to E prime greater than 15 in both groups here was associated with a much poorer survival, particularly in the group on the right-hand side of the screen here with a reduced ejection fraction. And this study found it was a very strong predictor of mortality. And this again highlights the importance of echo in not only establishing the diagnosis of HFpEF, but also in the prognosis for both patients with preserved and reduced ejection fractions. Well, a stiff left ventricle can lead to high left atrial pressure. And this will translate into high pressures into the pulmonary venous system and eventually into high pulmonary pressures. And all of this can lead to dyspnea. The high pulmonary pressures can lead to right heart failure because of a chronically increased RV afterload. So the RV may dilate, leading to secondary tricuspid regurgitation, and you've created a vicious cycle in a number of untreated or poorly treated patients. Now, everybody's familiar with the phases of diastole, and I'm not going to go through everything, but I wanted to highlight the IVRT, or the isovolumic relaxation time shown here, because it's an important variable in helping us to determine what filling pressures are in certain populations. Now, the IVRT is that period of time when both the aortic and mitral valves are closed and the LV pressure is declining. It marks the end of flow through the aortic valve here and the beginning of flow through the mitral valve here. So at that time, there's really no blood entering or exiting the LV cavity. And the IVRT tends to lengthen as we get older. But in patients who have restrictive filling patterns, it becomes very short. And this is because as the left atrial pressure rises, the mitral valve opens earlier, resulting in a very short IVRT. Now, these are the two algorithms that are used within the current guidelines. And the goal is really to simplify things, as I mentioned before, from the 2009 guidelines. So things like flow propagation and pulmonary vein flow, although useful in certain circumstances, play a very reduced role, if any, in 2016. The authors point out that it's important to look at what the two-dimensional image looks like, what does the heart look like, as well as assess the symptoms of the patient. Now, the first algorithm on the left-hand side of the screen here really addresses patients who have a normal ejection fraction and no evidence of heart disease to assess whether or not they actually even have diastolic dysfunction. And it analyzes the 4 parameters shown here in the blue box. Average E to E prime measurement, septal and lateral E prime velocities, TR velocity, and LA volume index. Now, the other side of the guidelines look at patients who have diastolic dysfunction. And we're really trying to determine to what degree the patient has diastolic dysfunction. It analyzes the same criteria that we can see on the other side of the screen, missing the absolute septal and lateral E-wave velocities. So let's spend a few minutes discussing some of the important parameters that are listed within the guidelines. The first is the E to A ratio, and I think everybody is aware that the E velocity normally decreases with age and the A velocity increases with age. It's important to remember that the E velocity is very volume dependent. So in patients with significant mitral regurgitation, you're going to get an exaggerated E wave velocity. There's clearly no A wave in patients who have atrial fibrillation. The other caveat to note is that you may get an E to A ratio that's greater than 2 in healthy young patients or healthy athletes. And this is because as the ventricle untwists, it almost creates a suction effect as blood comes from the left atrium into the left ventricle. The other thing to note is that in patients who have very dilated hearts, it's been shown that it's better to put the sample volume more laterally, as that's where the flow tends to be. Now, for the tissue Doppler parameters, we need to measure the lateral and the medial annuli. Now, the lateral annulus always has a, or not always, but typically has a E prime value that is higher than the medial. The medial tends to be anchored in that area of the mitral curtain. Be careful where you put the sample volume. It still is a Doppler measurement and it is angle dependent, but in the apical 4-chamber view, we can usually align the beam quite well. And you can see abnormality is determined as an E septal velocity less than 7, an E prime lateral velocity less than 10, and an E to E prime average greater than 14. If you only measure the septal side, you should have a velocity, a measurement greater than 15 to be abnormal. And if you're only measuring the lateral side, greater than 13 to be abnormal. What are some of the pitfalls with tissue Doppler? I think they're shown in these images here. If we look at the top left-hand side of the screen, it's not a perfect image, but it's a 4-chamber view of a patient who I think you can agree has pretty significant mitral annular calcification. On the right-hand side here, we've got a patient who has a mechanical prosthesis, and patients also who have had a mitral valve repair with an annuloplasty ring, you can't really use tissue Doppler in. And at the bottom of the screen here, we have a patient who has an infraseptal basilar wall motion abnormality. And again, you have to be careful of using tissue Doppler in that situation on the lateral side. The LA volume index is considered to be abnormal if it's greater than 34 mils per meter squared. But remember, there's other reasons for your left atrium to dilate. Chronic mitral regurgitation and atrial fibrillation are going to lead to left atrial dilation regardless of what your diastolic function is. Now, for the TR velocity, the cutoff abnormality is greater than 2.8 meters per second. And remember, you need a good signal. Don't guess as to where you think that the peak is going to be. Unless you can get a very clear signal, don't report it or measurement. The other caveat to note is remember to use agitated saline or contrast to enhance the signal. That can sometimes help bring out the signal to make that measurement possible. And also beware of severe tricuspid regurgitation because there's very rapid equilibration between the right ventricle and atrium under these circumstances, and it doesn't create reliable value. Okay, so this is the left-hand side algorithm that we initially showed, and this is for looking at patients with a normal left ventricle. And it's important to emphasize that the presence of a structurally normal left heart with a normal EF doesn't preclude the presence of diastolic dysfunction. However, under most circumstances, if the echo looks normal, there's likely no diastolic dysfunction. So the guidelines suggest that we need to look at these 4 variables to determine if a patient has diastolic dysfunction. And you can see if 3 of 4 of these are positive, the patient does have diastolic dysfunction. If only 2 are positive, it's considered to be indeterminate, and none or 1 positive, it's normal function. Now, if you can only measure 3 of the variables, 2 out of 3 need to be positive to have a diagnosis of diastolic dysfunction. Now, this second algorithm estimates the degree of diastolic dysfunction in 2 patient populations. Now, remember, if you have a reduced ejection fraction, you have abnormal diastolic function. This algorithm also includes those patients who have a normal ejection fraction, but they have signs of heart disease. And the guidelines are not entirely clear of what they mean by heart disease, but things like pathologic left ventricular hypertrophy or left atrial enlargement or reduced global longitudinal strain or wall motion abnormalities would all be things that you would consider heart disease. So a patient with a normal EF and one of those findings would end up on this side of the algorithm. So if we look at the entry point, the first entry point is really looking at the mitral inflow. On the left-hand side of the screen, you can see a patient who has an E to A ratio that is less than 0.8 and a very low E wave velocity at 50. In this particular patient, you can immediately go down here, and this patient has grade 1 diastolic dysfunction. You really don't need to do anything else. Conversely, if you have an E to A ratio that is greater than 2, such as this patient here, you can automatically say that this patient has grade 3 diastolic dysfunction. Everybody else, you would need to go through the algorithm through this middle section here. So basically, you're going to be looking at these 3 criteria: E to E prime, TR velocity, and LA volume index. If 2 of 3 or all of them are negative, the patient has grade 1 diastolic dysfunction. If 2 of 3 are positive or all 3 are positive, you have grade 2. Now, in circumstances where you can only measure 2 criteria, and it's typically the TR velocity we can't measure, if both are negative, you're considered to have grade 1. If 1 is positive and 1 is negative, it's indeterminate. And if both are positive, you have grade 2. Now, the guidelines talk about these terms, and that they use normal diastolic function or grade 1, grade 2, and grade 3. Grade 1 diastolic dysfunction essentially has normal left atrial pressures, where grade 2 and grade 3 have progressively worsening elevations in left atrial pressure. The other term that's used when you can't decide what the degree is you call it indeterminate. Now, it's important to note that the guidelines caution against the use of the algorithm to estimate mean left atrial pressure under certain circumstances. And this includes the things listed on the screen. Certainly anybody with more than moderate MR or mitral stenosis of any severity, prosthetic heart valves, annuloplasty, rings, severe MAC, hypertrophic cardiomyopathy, pericardial constriction, atrial fib and flutter, left bundle branch block, biventricular pacing, and LV assist devices. Alternative approaches for estimating pressure in a number of these disorders are discussed in greater detail in the guidelines, and I'll be highlighting a few of those in just a moment. Now, a simplified approach, I think some of these things to remember would be that the echocardiogram looks normal, it likely has normal diastolic function. If you want, you can quickly do an E to A ratio or a simple E prime lateral to confirm. And if your E prime lateral is 10, 15, 20, you know that that patient has normal function. If the patient has left heart disease but normal function, you can perform the E to A ratio. And as I mentioned earlier, if it's this pattern, they have grade 1. And if it's this pattern, they have grade 3. The other thing to remember is that if your TR velocity is greater than 2.8 meters per second, and you have evidence of left heart disease, you almost certainly have elevated filling pressures. Everything else in between will use the algorithm as well as our clinical and two-dimensional echo data to make a decision. Now, can you predict what Doppler pattern would correspond to this particular heart? Now, we can see here a patient with very, very poor left ventricular function. And you might automatically say that it would be this restrictive type pattern. And yes, if this patient had their initial presentation and they came to the emergency room, that might be the pattern you would expect to see if you did the Doppler tracing. However, if this patient was in fact admitted to hospital and had treatment with diuretics and perhaps SGLT2 inhibitors, you might notice a change to a pseudonormal or even a mild type pattern. So what I'd like to do now is go through some cases and apply the guidelines so it might hopefully make things a little bit more clear. So let's go back to that very first case that I showed you. And this is the 71-year-old lady with LVH and preserved systolic function. Remember, her E to A ratio was 0.8 with a peak E-wave velocity of 113. Her left atrial volume was normal. Her E to E prime was 14. And her TR velocity was 2.6. So if we go back to the guidelines here, we can see that her E to E prime was 14. It basically met criteria, but the TR velocity and the LA volume index did not meet criteria. So 2 out of 3 were negative. So this patient essentially has grade 1 diastolic dysfunction. This is a 46-year-old male who was admitted with shortness of breath on exertion and congestive heart failure. The apical 4-chamber view shown here shows relatively well-preserved systolic function, but the patient did have left ventricular hypertrophy. The E to A ratio you can see here was 1.5. The left atrial volume index was elevated at 40. And the E to E prime was elevated at 12. And we could not measure the TR velocity in this particular patient. So based on this information, we're in the middle part of the category here because remember our E to A ratio was 1.5. The LA volume index did meet criteria, but we weren't able to measure the TR velocity, and the E to E prime did not meet criteria. So we really only had 2 variables to evaluate. So one was positive and one was negative. So in this particular incidence, we would end up with a diagnosis of indeterminate. But this is a patient who certainly you highly suspect has diastolic dysfunction. And I think this would be one of those cases where it might be worthwhile using agitated saline or contrast to try and get that TR signal, because if it was greater than 2.8, this patient would have grade 2 diastolic dysfunction. And as we'll see later, there's other things that you may be able to do. Another thing that you could consider doing is measurement of left atrial strain or even a diastolic stress test to bring that patient out of the indeterminate category into perhaps grade 2. This is a 70-year-old female who had progressive dyspnea and edema. This is a parasternal long axis view that I think you'll agree the patient's left atrium looks enlarged. Systolic function is normal, but the walls are thick. E to A ratio was 1.3. Her TR velocity was 2.8 meters per second. The E to E prime in this particular case was 20. And the LA volume index was 39. So let's apply the guidelines here. And you can see that her E to E prime was 20. She met criteria. Her TR velocity was 2.8. And although the guidelines say greater than 2.8, I would accept that as elevated. And the LA volume index was big. So again, we fall into this side here where we have grade 2 diastolic dysfunction in this particular patient. The next example is a 72-year-old male with congestive heart failure. Not surprisingly, I think both on the parasternal long axis view and the fourth chamber on the right, you can see a very dilated heart. There's significant biventricular dysfunction in this patient. And from the initial slide, you can see that the LA volume is significantly elevated at 48. Now the E to A was 1.9, essentially sort of 2. So actually in this particular patient, we could probably stop right there, as I showed you on the previous slides, and we could just slide down to grade 3 diastolic dysfunction in this patient. But some of the other variables that we did measure, you can see the E to E prime was 26 and the TR velocity was 3.2. So all of those would suggest a patient who has grade 3 severe diastolic dysfunction. The last case I'll show you here is a 27-year-old male who was referred to the echo lab because of a murmur. This patient's heart looks entirely normal. So he would be evaluated by the very first algorithm to see whether or not he even has diastolic dysfunction. His E to A ratio was 2.6. You can see his E to E prime was only 6 and his LA volume index was normal at 27. We couldn't measure a TR signal in him. And this is the guidelines that we would use. And basically, he's going to fall into this side of the category because this is a very normal looking heart. And remember what I mentioned before about that E to A ratio being 2 in healthy young athletes or extremely healthy young patients due to the suction effect created by the untwisting of the left ventricle. Now, what about some of the special situations that we encounter in our patients? Certainly in mitral stenosis, you would not be advised to use the traditional algorithm. In patients who have mitral regurgitation and more than moderate MR, it's advised not to use the traditional algorithm. And I have to say that the utility of E to E prime in predicting LV filling pressures in the setting of moderate to severe MR is a bit more complex. What we do know is that in patients who have a poor ejection fraction and severe MR, a high E to E ratio has been shown to have significant relation to elevated left atrial pressure, and it does predict hospitalizations and mortalities. The E to E prime, however, does not appear as useful in patients with primary MR and a normal EF. What about mitral annular calcification? This is something that we see regularly in the echo lab that can make it challenging to assess diastolic function. This is a 4-chamber view in a patient who, it's not the best image in the world, but I think you can appreciate has pretty significant mitral annular calcification. What do we do in this circumstance? Well, Abadiab, publishing in JACC Cardiovascular Imaging in 2017, suggested using this approach, and they validated this in a number of patients. So if you have moderate to severe mitral annular calcification, they suggest using the E to A ratio initially. If it's less than 0.8, you have normal left atrial pressure. If it's greater than 1.8, your left atrial pressure is high. And everybody else in between, you need to measure the isovolumic relaxation time. Now, if that is very short and less than 80 milliseconds, you have high left atrial pressure. If it's greater than 80, it's considered to be normal. Now, how do we measure that? Now, one of the ways to measure IVRT is to look at an apical view, apical 5-chamber view, and you can place your sample volume midway between the LVOT and the mitral annulus. And what we're measuring here is that time from aortic valve closure to mitral valve opening. And in some cases, what we found is really using tissue Doppler to measure this is actually easier. So you can see on this particular slide, we have a cartoon of a tissue Doppler tracing. We have the S wave here, and then we have the beginning of the E prime wave. And you can measure the IVRT at the end of the S wave to the beginning of the E prime wave. And if you look below here at this particular tracing, you'll see an example. Here's the ending of the S wave, and there's the beginning of the E prime wave, and we can measure the IVRT in that particular patient. Let's look at an example of a patient who has mitral annular calcification. It's a 74-year-old male with chronic renal insufficiency and hypertension who had increased dyspnea on exertion. And again, this is a parasternal long axis view, thick heart, normal systolic function, probably big left atrium, and pretty significant annular calcification shown on the screen here. The E to A ratio was 1.5. And we didn't need this to use the algorithm, but out of interest, the TR velocity was 2.9. And the IVRT measured on the tissue Doppler here was 70 milliseconds. The left atrial volume out of interest was also big. So you can see here our E to A ratio was 1.5. We had to measure our IVRT to make the determination it was 70. So that particular patient would be graded as having grade 2 diastolic dysfunction based on that particular algorithm. Now, atrial fibrillation is also something that we encounter frequently. Remember that diastolic dysfunction causes left atrial dilation, which can lead to atrial fibrillation, and the presence of AF is not uncommon in patients we see with heart failure. In patients who have atrial fibrillation, the Doppler assessment of diastolic function is limited by a number of things: the variability in the R to R interval, the absence of an A wave, and the frequent occurrence of LA enlargement, regardless of what the filling pressures are. So in general, when the left ventricular ejection fraction is depressed in patients who have atrial fibrillation, a deceleration time on the E wave of less than 160 milliseconds has very good accuracy in suggesting that the left atrial pressure is elevated. So let me just repeat that. If you have a reduced ejection fraction and your deceleration time is less than 160 meters per second in patients with atrial fibrillation, that suggests elevated left atrial pressure. In other patients, certainly those with normal EFs, you can use the septal EDE prime, and it's been shown that a septal EDE prime of greater than 11 and a short isovolumic relaxation time, less than 65 in this population, has been shown to predict elevated left atrial pressure and point to adverse clinical outcomes. One other additional clue that I'd like to share with you in suggesting the presence of elevated left atrial pressure and atrial fibrillation is the lack of variability in the peak E wave velocity despite varying RR intervals. And I'll show you an example of this shortly. So the E wave does not change in its velocity, and this is because if the left atrial pressure is constantly elevated, the transmitral velocity will tend to be high throughout the variations in the cycle length. And it is important to average 5 to 10 beats in these patients. But let's look at an example. This is an 83-year-old female with dyspnea and atrial fibrillation. Parasternal long axis view on the left, apical four-chamber on the right. We have relatively well-preserved systolic function, a thick heart, and a big left atrium, which you can really appreciate from the four-chamber view. In this particular patient, the septal ED prime measurement was 20, and the IVRT that we measured on the tissue Doppler was 60. So both of those criteria would suggest that this patient has elevated left atrial pressure. And what I had mentioned before about the lack of variability about the E wave velocity is shown here. You can see that despite the varying RR interval, that E wave velocity tends to stay the same. And this is highly suggestive of elevated left atrial pressure in this population. The other thing is the L wave. Now, during the period of diastasis, you may see a very small L wave in normal people who have slow heart rates. However, in patients who have atrial fibrillation, it's a strong marker of diastolic dysfunction. And the L wave really represents continued pulmonary vein mid-diastolic flow from the LA into the LV after the time of early rapid filling. And you can see on the top part of the screen here, this is a normal example where you have an E wave and A wave, and this is your L wave here. Below it is a patient with atrial fibrillation, and you can see the L wave here, which is highly suggestive in this population of elevated left atrial pressure. Don't confuse the L wave with an A wave. Certainly in atrial fibrillation, you won't have an A wave, but remember that the L wave occurs far earlier than the A wave. The A wave should occur just before the QRS complex, just at the end of diastole. Now, left atrial strain is an important variable that will definitely play a role in the new guidelines. And as we know, the left atrium plays a critical role in maintaining LV filling, functioning as a reservoir for pulmonary venous flow during LV systole, as a conduit for blood flow into the LV during early diastole, and as a booster pump during late diastole. A dysfunction of these normal left atrial mechanics impairs LV filling and reduces overall cardiovascular function. And it's been implicated in the development of HFpEF. So the size and the function of the left atrium serves as a surrogate for LV diastolic dysfunction. And you can see LA strain being measured in this particular example on your screen. And it's usually something we can get in the vast majority of patients from the apical 4-chamber view. And there have been studies that show that using invasive hemodynamics, left atrial reservoir strain is a better predictor of an LV EDP greater than 12 than the mean E to E prime ratio. In this particular study by Singh et al. In JACC Cardiovascular Imaging in 2017, these authors looked at testing LA strain thresholds for different degrees of diastolic dysfunction in patients who had a normal ventricle. And you can see on the screen here that as you went from grade 1 to grade 3, there is significantly different strain values with gradual decreases seen as you had worsening diastolic dysfunction. And I'd like to end with this slide here, and it was recently a part of the article in the European Heart Journal of Cardiovascular Imaging on multimodality imaging in patients with HFpEF. And it's very interesting because what you see here is really the second algorithm that I've been discussing. And what these authors have suggested is using LA reservoir strain to replace a missing variable. So as I had mentioned earlier, TR velocity may be challenging to get in many of our patients. So if you're unable to get that and you can measure LA reservoir strain, if your LA reservoir strain is less than 18%, that's highly suggestive that you have elevated filling pressures. So I'd like to conclude here and simply say that I think diastolic function is really important for diagnosis, treatment, and prognosis. I think it's important to follow the algorithms, but remember to look at what your two-dimensional image looks like and take into account the patient's history because it's very important. When a variable is missing, it will almost always be tricuspid regurgitation, and you can consider using agitated saline or contrast to enhance that signal. Left atrial strain may be something that we use in the future on a regular basis. Beware of the special situations for which the guidelines are not intended, which we had gone through. And I haven't gone through everything, but there's also special algorithms for things like hypertrophic cardiomyopathy as well. And there are other investigations that will be helpful in this population, such as left atrial strain and diastolic stress testing, because some of these patients may only have symptoms when they exercise. Thank you very much.
Scott, it is always a pleasure to hear you, and you make the concept so crystal clear. We are really fortunate to have you in our group. Thank you very much. And we will take the questions in the end. And I will request Dr. Kathirvel if he can just show his first slide. Can you go to the full? Yes. So Dr. Kathirvel Subramaniam, he is the professor and section head of the cardiothoracic anesthesia at University of Pittsburgh Medical Center, Pittsburgh. And his area of interest is enhanced recovery in cardiac anesthesia, perioperative TTE, TE, organ transplantation. He has been an eloquent speaker in the American Society of Anesthesiology meetings, as well as many of our Indian Society meetings. So, Dr. Kathirvel, please.
Thank you, Virendra, and thank you for the College of Anesthesiologists for the invitation to speak. And this is really an honor. And I will be speaking today about recent advances in management of postoperative coagulopathy in cardiac surgery. So I'll just start with a case which we had 2 days before in the middle of the night. This is routine 65-year-old woman, hypertension, hyperlipidemia, depression, no other past medical history. She presented with type A acute aortic dissection. There was no rupture, no coronary involvement. She planned to undergo hemiarch under deep hypothermic circulatory arrest. All coagulation studies normal to start with, no anticoagulation on board. So the surgeon, before starting the case, he was asking for 2 cryoprecipitate, 2 platelets, and PCC before he even started the case. So how, as anesthesiologists, we respond to these requests? And can we just go blindly by the surgeon's request, or we use our scientific rationale? So we go through each phase, preoperative, intraoperative, and postoperative here, how we can manage anesthesia, perfusion, surgical, surgeon, and go from there. So patient blood management is a close interaction with surgeon, anesthesiology, intensivist, and perfusion. There are several predictors of bleeding and coagulopathy and transfusion in cardiac surgery: advanced age, female gender, small body surface area, if you patient on platelet therapy, antiplatelet therapy, poor platelet function, preoperative anemia, you are undergoing emergent surgery, non-cabbage, combined surgical procedures, redo surgical. These are some of the risk factors. And we have no doubt if you give more transfusion, it gives bad outcomes. There is enough evidence in the literature to say in cardiac surgery, transplant surgery, simple cabbage surgery, if you give more blood transfusion, bad outcomes will happen. There is argument whether the transfusion is an indicator of outcome or is an indication of a complex surgery. That argument will never end, but we know from independent multivariable analysis from multiple big data studies that if you give more red cell transfusion, it will produce bad outcomes. So let's start from preoperative phase. So what is the preoperative testing we can do? We know that preoperative fibrinogen levels may be considered to identify patients at high risk for bleeding. The other testing, like viscoelastic testing or platelet function testing, is not recommended to predict bleeding in patients without antithrombotic treatment. Platelet function testing, like a P2 white-well assay, can be used in patients taking Plavix or other drugs which affect platelet function. So it's an interesting recommendation from European Society of Anesthesia and European Society of Surgery, Cardiothoracic Surgery. So fibrinogen is indicated, other testing may not be indicated. So if you have a patient taking antiplatelet therapy, aspirin can be safely continued if the patient has to undergo elective surgery. But if the patient has to undergo elective surgery with Plavix, that's not good. So you should stop P2 white-well inhibitors before surgery. So there are two things. If a patient has a high risk for bleeding, it's a redo case or multiple risk factors for bleeding, as I mentioned, aspirin can be stopped in high-risk patients. In patients taking Plavix, if you stop Plavix, consider bridging with GP2B or 3A blockers in patients with high thromboembolic risk. And what are those risk factors? They're patients with mechanical heart valves, patients with atrial fibrillation with rheumatic heart disease, patients with acute thromboembolic events in the last 4 weeks, or if you have an atrial fibrillation with CHA2DS2-VASc scores more than 4. So these are all some of the patients where if you stop anticoagulation, you may have to bridge these patients. There are several recommendations from several societies where you stop these drugs. If you have a anticoagulation with dabigatran, you may have to stop 48 hours before surgery. If the patient is taking low molecular weight heparin 12 hours before surgery, G2B, 3B inhibitors discontinue 4 hours before surgery. This slide indicates when you stop, when you restart. So it's important to know when to stop, also when to restart anticoagulation. Otherwise, the patients will end up in thromboembolic complications. There are definite recommendations from societies. I don't need to go through in detail about it. Direct thrombin inhibitors and factor 10A inhibitors are increasing in use in patients with atrial fibrillation or venous thromboembolic disease. They have special problems. You cannot detect their action by regular coagulation studies. You have to do a thrombin time or acrine clotting time. And the reversal of these agents is a problem. So this is a commonly used drug like apixaban, rivaroxaban, or patients with dabigatran. So two things to know is all these drugs have a renal elimination. So if you have a patient on these drugs, always look into what is the serum creatinine level, what is the GFR. So 48 hours recommendation is for patients with normal renal function. So if you have a serum creatinine high, you may have to hold this drug for 72 hours, maybe longer. So that's something to remember. Is there an antidote for these agents like Coumadin? Like, no, actually in cardiac surgery, we don't reverse these agents if for patients undergoing elective surgery with these antidotes. However, if you reverse these patients with antidotes, there is an indication these patients will be hard to anticoagulate with heparin, especially if you reverse these patients pre-bypass. Post-bypass reversal may be okay, but if you reverse these patients pre-bypass, you will not be able to anticoagulate satisfactorily with heparin. So that will be a problem to remember. A second thing I want to bring out is preoperative anemia has been given a lot of attention nowadays. So we look at these patients undergoing cardiac elective surgery in preoperative clinic all the time. Investigate in detail for preoperative anemia. You look at the reticulocyte count. You look at whether it's a macrocytic or microcytic or normocytic anemia. Then look for hemoglobin levels, ferritin levels, transferrin saturation to diagnose an iron deficiency anemia. So if you know this patient has an iron deficiency anemia, then anesthesiologists, we ourselves recommend oral iron or IV iron based on when the surgery is going to happen. This has a role for Center for Pre-Surgical Care. Some patients also have folate deficiency, B12 deficiency, leading to macrocytic anemia that can be treated. But if the patient has normocytic anemia, then erythropoietin may be indicated in this patient. So patients should be seen in the preoperative period. Anemia treatment by anesthesiologist is, a growing field. How to treat oral iron or IV iron or hematology consultation in special cases or erythropoietin from renal failure or normocytic anemia. All these things should be sorted out preoperatively rather than on the day of surgery. And surgeons always consult us at our institution, so it makes our life very easier. So there are several improvements that can be done intraoperatively during bypass or pre-bypass to make sure the transfusion requirements are minimized. There are several institutions where they use minimally invasive extracorporeal circuit with minimum volume, priming volume, so that hemodilution is decreased and the transfusion requirements are reduced. Other strategies include you can do an off-pump coronary surgery or minimally invasive coronary surgery. The topical drugs, closed CPV system, like a minimally invasive system, or biocompatible coating of the circuits and tubings that can also reduce the activation of the coagulation factors during surgery. Cell salvage, this has been given a special attention. If you do cell salvage as opposed to cardiotomy section, that may decrease the inflammatory mediators, also decrease the transfusions. Ultrafiltration, modified ultrafiltration have a role. Retrograde and antegrade autologous priming before going on bypass is a common practice at our institution to reduce the transfusion requirement. As we all know, hypothermia is also an indication for coagulopathy. So we have to take all the steps possible. It is a challenge in patients with minimally invasive surgeries or off-pump cases to keep the patient, especially in hybrid rooms. There is no real way to warm these patients. So it's the surgeon, OR nursing, all have to cooperate to avoid hypothermia in such patients. So this is a study where they have shown that using a cell saver during the case rather than cardiotomy section, you have the percentage reduction in fat weight is very, very high, 87% in cell saver use compared to cardiotomy section. So that what that means is if you use the cardiotomy section, basically you are going to have more inflammatory mediators, more fat elements. So that will cause increase in transfusion requirements. Individualized heparinized management, is that have a role? It's not clear. We always use ACT to titrate heparin. Anybody using heparin levels to titrate, or will it have an impact on transfusion? It's not yet clear. But what is clear in cardiopulmonary bypass cases is you use very, very less protamine to reverse heparin. You can always give more. If you give more protamine, like a 1.3 ratio, it will increase the transfusion rate. So what we use our institution is 0.8 to 1 ratio. So if we use 100 milligram of heparin, you use 80 milligram of protamine to reverse. 83 has if you give prophylactically without an indication, it will increase transfusion rate. So we have to be cautious while using 83 only for proven cases of heparin resistance. HIT patients is a special concern because you cannot use heparin, you cannot reverse heparin. Bivalirudin with renal elimination is always a problem when you use for full heparinization patients, like a full cardiopulmonary bypass cases. Heparin plus antiplatelet strategy is used at our institution. Plasmapheresis is used some institution, but again, it is not proven. So special role for pre-donation or pre-operative collection of blood. So this is a study done with autologous blood collection in aortic surgery with hypothermic arrest at Cleveland Clinic, where they propensity matched autologous whole blood versus non-autologous whole blood transfusion recipients. So what they have shown is the transfusion rate intraoperatively or during entire hospital stay, including red cells, plasma, platelets, cryoprecipitate. Everything is decreased if you use autologous whole blood. So in this study, they collected around 800 cc on an average for autologous blood. So if you collect maybe 2 units of blood before going on bypass without hemodilution, we use it without hemodilution. We don't use crystalloids to compensate for the amount of blood taken out. We use vasopressors. We try to manage the blood pressure without giving a lot of crystalloids. In that case, it will be very useful to decrease transfusion. Antifibrinolytic, this can be a lecture by itself. There are a lot of controversies, as we know. They are definitely more effective than placebo in reducing blood loss and transfusions. Tranexamic acid and aminocaproic acid, both are effective. Proteinin is not used in United States. I'm sure it is used in Canada and other countries. Tranexamic acid at higher doses can cause seizures. There are no optimal dose response studies. What we use our practice is tranexamic acid 10 milligram per kilo bolus, followed by 1 milligram per kilo per hour. Institutional practice vary, but universal recommendation is antifibrinolytics are very effective in reducing transfusion in cardiac surgery. Again, there are a lot of literature recently on factor concentrate. Let us go through some of those studies. This is a study on fibrinogen concentrate versus placebo in patients undergoing high-risk cardiac surgery. They had 120 patients randomized fibrinogen concentration versus placebo. What is the inclusion criteria? They looked at the blood volume between 60 cc and 250 cc suctioned from thoracic cavity in 5 minutes after protamine has been infused. So when the blood volume is less than 60, they thought it's not necessary to, it's not a complex case you can manage. When the blood volume is more than 250 cc's, they think it's a surgical bleeding. So they told the surgeon, you can control the surgical bleeding. So if that is in between, they thought it is a microvascular bleeding, and they preferred fibrinogen or placebo. Dosing of fibrinogen concentrate is based on the levels, fibrinogen level at the end of cardiopulmonary bypass. So this is what came out. The cumulative 24 hours blood loss was around 120 cc's higher in control patients, statistically significant, but clinically not relevant. So according to them, in this study, fibrinogen concentrate compared to placebo did not reduce intraoperative blood loss in high-risk cardiac surgery. So this is basically a negative study with respect to placebo. There is another study published in British Journal. Again, they used the same criteria. 50 to 250 gram was the inclusion criteria, bleeding. Dosing of fibrinogen concentrate was based on FibTem on TEM monitor, maximum firmness values at 22. They targeted TEM values to 22. Transfusion 24 hours is the primary outcome. So you can see the transfusion at 24 hours were higher in patients received fibrinogen concentrate compared to placebo. So, they were not clear why this happened even with fibrinogen concentrate. They did a post hoc analysis and they could not find the reason. So again, this is a negative study showing fibrinogen concentrate is not superior to placebo. And here come two different studies published in Journal of American Heart Association. They again included patients undergoing complex heart surgery. They randomized to fibrinogen concentrate and placebo. The primary outcome was avoidance of blood transfusion. Just to rehearse that, there are two studies which have shown no clinical efficacy of fibrinogen concentrate compared to placebo. There are two other studies have shown a positive effect of giving fibrinogen concentrate compared to placebo. And this is one of the study from Anesthesiology. They gave after bypass if the FibTem MCF is more than 22, they have given either placebo or fibrinogen concentrate. And they have shown the transfusion for 24 hours after infusion of study medication significantly reduced with the use of fibrinogen concentrates. So how to conclude this? Low fibrinogen levels with persistent microvascular bleeding can be an indication for fibrinogen concentrate. Safety profile needs to be confirmed with further clinical trials. Several institutions use FibTem. The other institution use serum fibrinogen levels. Here is the most important study. I know several institutions use cryoprecipitate. Doing a placebo-controlled study on fibrinogen concentrate may not be an ideal comparison because we already have a product which gives fibrinogen, which is cryoprecipitate. At least our institution in the United States, cryoprecipitate is widely used. So is this fibrinogen concentrate superior or non-inferior to cryoprecipitate? They try to study that. This aim of the study is to prove the fibrinogen concentrate is non-inferior to cryoprecipitate. So this is a randomized clinical trial done throughout Canadian hospitals, a large volume of population, to rehearse that those 4 studies which I presented. They studied only less than 100 patients in each group. And here you can see 372 patients received fibrinogen concentrate and 363 patients received cryoprecipitate. The way they have given is fibrinogen concentrate was given 4 gram over 10 minutes. During 24 hours, if you find the need for fibrinogen, they can give that. So in patients with cryoprecipitate group, they gave 10 units of cryoprecipitate over 24 hours. So they can administer, they didn't clearly mention how much was given, how many times it was given, but I will say that they compared over 24 hours administration of fibrinogen concentrate versus cryoprecipitate. And the mean blood administration units, you can see 16.3 units in this group versus 17 units in cryoprecipitate group. That's really a high volume transfusion. They included red cells, they included FFP, they included platelets, all blood component transfusion in this. Still, giving a 16 units in 24 hours is quite a bit in these cases. So that, that's not a common practice, even in aortic surgeries at our institution. So there may be some limitations in the study, but to conclude, the cryoprecipitate and fibrinogen concentrate are as effective to each other. So coming to prothrombin complex concentrate, which is in common use, it is an FDA approved product at the United States for reversal of Coumadin, whether to use in post-bypass bleeding, post-cardiopulmonary bypass coagulopathy. It's really controversial. And this is the study cleared that aspect. When the patient is bleeding after protamine administration significantly, they have either randomized to PCC or plasma, though this is a small study, 51 patients in PCC group, 49 patients in plasma group. They administered 15 units per kilo, or closest standardized dose in PCC. So to reverse Coumadin of an INR of 3, you usually give 30 to 40 units per kilo body weight. So kind of off the dose they have given. Again, the plasma group received 10 to 15 ml per kilo rounded to the nearest unit. And they have shown non-inferiority, no significant difference in chest tube output or transfusions in those 2 groups. So PCC is as effective. Again, the safety profile with this 50 patients and 49 groups is not really to confirm, but they have shown the efficacy of PCC, and there was no increase in side effects demonstrated with PCC administration in these patients. So it's an increasingly used in cardiac surgical patients instead of plasma, at least as a non-labeled use. So this is data showing the transfusion is not changed with whether PCC or plasma. The side effects, again, not different between plasma or PCC. So recombinant 7, factor 7, this has disappeared from use. Initially, when it was popular, when it came, they have shown no reduction in transfusion rates if used prophylactic or therapeutic, but increased incidence of thromboembolic complications role. So it is not recommended for clinical use. the last resort in uncontrollable bleeding. After the PCC was given, platelets were given, cryo was given. If the patient is still bleeding and surgically it's not controllable, you can attempt after documentation recombinant factor 7A, but it's not recommended as a first-line treatment as a prophylactic or therapeutic. DDAVP, it stimulates the release of von Willebrand factor from endothelial cell. It has some special utility in special groups, patient on antiplatelet drugs, patients with a reduced platelet function, patients with prolonged bypass, impaired renal function, or aortic stenosis, where the patient has von Willebrand deficiency. There is a risk of hypotension with DDAVP if you administer fast, but there is no other complications involved. So we all know that if you use TEG or ROTEM or the new Quantra, the transfusion, if you use algorithmic approach in cardiac surgery, the reduction in transfusion rate can be achieved, though there won't be change in chest bleeding or re-exploration, but there definitely transfusion, some scientific rationale can be applied to transfusion management using point of care coagulation tests. So there is also to the study targeting liberal transfusion versus restrictive transfusion. So you want to transfuse when the hemoglobin drops to 7.5. Do you wait, or you transfuse when the hemoglobin is only 9.5? So this has been answered by a large study from Canada again, 5,000 patients, 2,000 almost in each group. They strictly followed the protocol here. You can see the liberal group received, hemoglobin at a higher concentration, restrictive group at a lower concentration. And the primary outcome measure, which is a composite outcome of mortality, stroke, myocardial infarction, renal failure, all these things combined together, is not different between a liberal transfusion or restrictive transfusion. So if you can save money by restrictive transfusion, then why do you want to use a liberal transfusion? So that is at the document, this is a scientific rationale for restricting transfusion and provide the same outcomes. The ECMO and extracorporeal circulation is a growing field. There is a fall of heparin in this area. The rise of bivalvular ergotrobon to use in these patients. In our ICU, we replaced the use of heparin in the ECMO patients completely with bivalvular and ergotrobin. So how will you monitor is questionable. What is the dose to use is questionable. Again, this has been to avoid heparin-induced side effects. Like heparin-induced bleeding, heparin-induced thrombocytopenia is a significant problem. So to avoid that, the alternate anticoagulants are increasingly used. The comparative studies are lacking. In our institution, at least we reported our case series, providing comparable outcomes with alternate anticoagulation. So going back to the case history, the aortic dissection case without any risk factors, we did a hemiarch, came off bypass. Our baseline TEG was normal. We used TEG in our institution. We always send a heparinase TEG when we were rewarming around 29, 28 degrees. The maximum amplitude was decreased, indicating platelet or fibrinogen deficiency. Otherwise, it was normal. R time, K time was normal. Angle was slightly decreased. We also send a coagulation profile, mini coagulation profile, which has fibrinogen and platelets. And this is what we came up with. Fibrinogen was 140 milligram. Platelets were 85,000. So we, as we discussed before the case, the patient received cryo and platelets, 2 units of cryo, 2 units of platelets, which normalized. We repeated the TEG, which was normal. So no PCC was given to the patient. No red cell transfusion was given to the patient. So when the surgeon says transfuse blindly, you can apply scientific rationale by doing some point of care coagulation tests and guide the coagulation therapy to avoid transfusion. That is strongly recommended, and that's what it done in this patient. This patient did not have excessive chest tube bleeding post-operatively, did not receive any more transfusion post-operatively. The patient did not come back to the OR for re-exploration, producing a good outcome even with deep hypothermic circulatory arrest. That is the end of my lecture. I'm open to questions. And again, thank you for the opportunity.
May I request Dr. Camila if she can show her first slide?
For sure. 1 second.
You have started screen share.
Okay, so welcome, Dr. Camila Machado. Dr. D'Souza is our most dynamic assistant professor. She joined our group from Brazil. She did her fellowship in cardiac anesthesia at University of Manitoba, and after completing that, she started working as a assistant professor in cardiothoracic and vascular anesthesia. She is actually leader for the thoracic anesthesia also in our group, and she and Gordon Lee were instrumental for starting the minimal invasive cardiac anesthesia at our setup. And now she is also the program director, fellowship program director for University of Manitoba in cardiothoracic anesthesia. So Dr. Camila, please.
Thank you, Virendra, for the kind introduction. Hi, everyone. Good evening. Thanks to the Indian College for the invitation. It's a pleasure to be here tonight and talk to you about minimal invasive cardiac surgery and its most important anesthetic implications. I don't have any conflicts of interest regarding this presentation, so I'm just going to jump right into it. I want to start with a definition. Minimal invasive cardiac surgery, or MICS, is, as defined by the American Heart Association, is essentially any cardiac surgery performed through a small chest wall incision that doesn't include a full sternotomy. And the spectrum of MICS is quite broad. There's a variety of procedures that can be performed through a minimally invasive approach.
Okay, Arya, to everyone. We do not have aprotomin in Canada, and in our institution, we only use TXA.
Okay, so as I was saying, the scope of minimally invasive surgery is quite broad. We can do different things from coronary bypass, valve repair, replacement, extraction of intracardiac tumors, repair of atrial septal defects, and the list keeps growing as technology evolves and our expertise evolves. These procedures can be performed on cardiopulmonary bypass or off pump, and the minimally invasive approach creates a number of challenges for us. There are implications of it on every aspect of the perioperative care of these patients, from the pre-op, intra-op, and post-op management. And that's exactly what I'm hoping to discuss over the next few minutes. My objectives today are, first of all, to overview some of the surgical procedures with a focus on the main steps and the differences from a standard approach. I will discuss a little bit of the management of one lung ventilation, the importance of TEE for MICS, and some strategies to minimize postoperative pain. The first important consideration here really is patient selection. The ideal patient for MICS is slim, has normal femoral veins, and non-complicated pathology. There are a number of factors that can make the minimally invasive approach more challenging and higher risk. Chest wall deformities can complicate the surgical access. Previous thoracotomy and the presence of adhesions can impair adequate lung collapse. Patients with lung disease have to be carefully selected depending on the severity of the disease. They may not tolerate one lung ventilation. The presence of aortic regurgitation can be a problem because in most of these procedures, when cardiopulmonary bypass is required, we use antegrade perfusion for myocardial protection and to arrest the heart. So the presence of severe aortic regurgitation is a contraindication. The presence of an IVC filter is a problem because we typically use peripheral cannulation to establish cardiopulmonary bypass for these cases. For the same reason, patients with severe atherosclerotic disease of the aorta or severe peripheral vascular disease are normally poor candidates for this approach. The mixed procedures typically take longer. CPB duration is normally longer for these cases. So patients with significant comorbidities have to be very carefully considered, especially those patients with baseline poor RV function and severe pulmonary hypertension. And last but not least, ideally, there can't be any contraindications for transesophageal echocardiogram, considering that this is an essential monitor in these cases, and I will come back to this in just a moment. The majority of these procedures require a thoracotomy, and a range of additional incisions and ports are introduced depending on the surgeon's preference and the approach for cardiopulmonary bypass or myocardial protection. There is typically a working port for the camera, a small incision for the aortic cross clamp, and a few other incisions depending on the case and the need for special instruments. The patients sometimes will be supine, but most of the times they're in this semi-lateral position with the non-dependent shoulder and arm kind of dropping down and tucked to the side. There is a lot of potential for injuries here, and we have to make sure all the pressure points are sufficiently padded and special attention to the neck to avoid hyperextension, which could result in injuries such as brachial plexus injuries. In terms of monitors, external defibrillator pads are applied in all these patients in case we need to cardiovert or defibrillate, because the use of internal pads would be very difficult, most times not feasible or straightforward, since we have very limited access to the heart, different from the sternotomy approach. And in terms of other monitors, other than the routine invasive monitors we typically use in cardiac OR, such as an art line, CVP, PA catheters, I think it's worth mentioning cerebral oximetry. We use cerebral oximetry for most of our cardiac cases these days, but if you're in a center where this monitor is only used for selected cases, I would argue that the minimally invasive procedures should definitely be one to consider. As I've mentioned before, most of the time we're doing one lung ventilation for these cases, and hypoxemia is a common complication. We may be working with very borderline normal arterial pressures of oxygen, so having cerebral oximetry is kind of reassuring in these situations. You kind of know how low can you go, how much hypoxia is acceptable based on how much perfusion the brain is receiving. Another factor to consider is the fact that, as I mentioned before, quite often we'll do peripheral cannulation for these cases. And during that brief period of time between going on bypass and actually cross-clamping the aorta, the brain will receive most of its perfusion from the beating heart. And depending on how much flow is crossing the lungs, this blood may be more or less oxygenated. So cerebral oximetry will tell you right away if the brain is receiving enough oxygen or not. And a lot of times we are doing bicaval cannulation for some of these cases. So I think cerebral oximetry in these situations just adds another layer of safety to the procedure. If the plan is to use an endo balloon to include the aorta instead of a cross clamp, then we have to be very careful about the adequate position of this device. If the device migrates distally, it will end up occluding some of the arch branches, leading to either brain ischemia or limb ischemia. In these situations, the cerebral oximetry will tell you right away if severe ischemia is going on. It's also recommended that for those cases, we use 2 arterial lines, 1 on each arm. And regarding the intraoperative management of these cases, I think the main anesthetic consideration here really is that most of these patients will need 1 lung ventilation. And hypoxemia is the most frequent complication from 1 lung ventilation. Hypoxemia happens because of mostly 2 reasons. First of all, when we initiate a lung 1 lung ventilation, when we isolate 1 lung, we immediately create a big intrapulmonary shunt. The lung that collapses is not ventilated, but continues to be perfused. And hypoxemia is aggravated by what's happening in the lung we're ventilating. Multiple units of the ventilated lung will develop low VQ ratios or shunt. And shunt develops in the dependent lung for multiple reasons. There is the reduction in functional residual capacity, that is usual whenever we induce a general anesthetic, plus a tendency towards formation of atelectasis for multiple reasons. Muscle relaxation, the weight of abdominal organs and mediastinal structures compressing the dependent lung. Also, the lateral position, all these things combined contribute to an increase in number of units with low VQ ratio, creating shunt in the dependent lung that also contributes to hypoxemia. The situation can be made worse if we are isolating, for instance, the right lung. And that's just because the right lung is a bigger lung. There's a bigger tissue mass. It receives a higher proportion of the cardiac output. So intrapulmonary shunt will be slightly higher when we're isolating the right lung, and that contributes to hypoxemia. And the same goes for position. When we perform 1 lung ventilation in the supine position, the risk of hypoxemia is slightly elevated compared to the oblique or lateral position. Another common problem during 1 lung ventilation is hypercarbia. And this combination of hypoxemia and hypercarbia increase pulmonary vascular resistance, increase the risk for arrhythmias, also increases the sympathetic tone. And as you can imagine, this combination of things is likely poorly tolerated in a population of patients that most of the times already has some degree of pulmonary hypertension, some degree of RV dysfunction, tricuspid regurgitation, as well as other comorbidities. So really 1 lung ventilation is what makes these procedures more challenging for the anesthesiologist compared to other cardiac cases where that we're used to doing all the time. In order to perform one lung ventilation, we have to separate the lungs, and there are a number of devices we can use for that. The most common ones are the double lumen tubes and bronchial blockers. Both of them have a series of advantages and disadvantages. With the double lumen tube will give us access to both lungs. So it's great for aspirating secretions. It can be placed without bronchoscopy, although I'm not necessarily recommending we do that. And the main disadvantages are, first of all, it comes in limited sizes, which is rarely a problem in the adult population. It is a bulky and bigger tube, so placement can be traumatic or more traumatic compared to a regular single lumen tube. And another big disadvantage is that you will have to replace this tube at the end of the procedure. If the patient remains intubated and requires mechanical ventilation, you need to replace the double lumen tube before transferring this patient to ICU. And a lot of times at the end of a complex case like this, patients can be a bit unstable, more labile from a hemodynamic perspective. Not to mention that after hours of surgery and fluid shifts, there's more edema to the airways. So a tube exchange in this situation is not as straightforward. So I personally think that this is a disadvantage because it just adds a risk and another unnecessary layer of complexity to this procedure. The main advantage of the bronchial blockers in this situation is that it can be inserted through a regular endotracheal tube, so you don't have to worry about exchanging the tube at the end of the case. It's also great for patients who are already intubated because the tube serves as a conduit for the bronchial blocker insertion. You don't have to switch anything. It's not great for aspirating secretions. The lumen of these catheters is very narrow, so it's really hard to aspirate blood and thick secretions. Fortunately, that's rarely a problem during cardiac cases. It's more of a problem when we're doing lung resections, but not necessarily during cardiac cases. Insertion is not as straightforward as with a double lumen tube. You will need bronchoscopy here and really some familiarity with basic bronchoscopy skills to be successful. Lung collapse can be slower compared to the double lumen tube, but the final result, the quality of isolation is not inferior. There's plenty of literature to support that, and I think it's important to highlight this difference. Honestly, there are a number of strategies you can use to mitigate that, to accelerate lung collapse if you are using a bronchial blocker. I'm biased. I personally think that bronchial blockers are the best devices for these procedures. They are my first choice of method for lung isolation outside of the thoracic OR. And I can't say I've had major problems with lung collapse and lung isolation during the mixed cases I've been involved because I was using a bronchial blocker. As I've mentioned before, peripheral cannulation through the femoral vessels is the most popular approach to establish cardiopulmonary bypass during these cases. We rely on TEE to assist with the insertions of both the arterial cannula and the venous cannula. As I'm sure you know, peripheral cannulation is associated with a number of risks and complications. It's not an exaggeration to say some of these can be life-threatening, especially when they happen in a patient who's fully heparinized and has severe cardiovascular disease, which is typically the case in the cardiac ORs. So peripheral cannulation is a crucial step for mixed procedures, and we should be absolutely attentive to it. Surgeons rely on our TEE guidance to facilitate cannulation, and it is well described in the literature that this reduces the risk of complications, so it's absolutely important that we participate in it. When bicaval cannulation is indicated, the SVC cannula is typically inserted from the neck, either by us when we're putting the central line or by the surgeons. It can be anywhere, the cannula can be anywhere between 12 and 16 French, so it's a big cannula, but there is normally space for both our central line and the venous cannula in the same jugular. Alternatively, the central line can be moved to the left side. We should never use the left side for the venous cannulation because the trajectory towards the right atrium coming from the left is more tortuous, and there's higher risk for vascular injuries in this situation. The external cross clamping is the most common alternative used for aortic cross clamping in these procedures. The clamp goes directly through the chest wall and across the ascending aorta. It's placed under direct vision by the surgeons, as demonstrated in this short video. If for whatever reason cross clamping is not an option, we can use these catheters, the endo balloons, to occlude the ascending aorta. These catheters are typically inserted via the femoral artery or the subclavian artery under TEE guidance. And the final position is in the distal ascending aorta. If the catheter migrates distally, it will end up causing either cerebral ischemia or limb ischemia because of occlusion of one of the arch branches. And as I've mentioned before, we can monitor this with bilateral arterial lines and cerebral oximetry. If the balloon is placed too proximately, it can compromise delivery of cardioplegia to the coronary ostia. So those are things to look for when assisting with positioning of this device. When an external cross clamp is used, the aortic root is typically directly cannulated by the surgeons, and antegrade cardioplegia is our usual choice for myocardial protection in these cases. So it's very important that we rule out the presence of anything more than mild to moderate aortic regurgitation. It's important to remember that with a thoracotomy approach, topical cooling of the heart is more difficult to achieve. So more often the surgeons will request systemic cooling as an alternative to optimize myocardial protection. And most of the times the surgeons will be using single dose del nido cardioplegia for these cases. And we have to be careful and remember that this is we're using single dose cardioplegia, especially in high risk procedures and procedures with prolonged cross clamp times. Retrograde cardioplegia can be used. The coronary sinus can be directed, cannulated by the surgeon, although I'm told by my colleagues this is extremely challenging. So if necessary, what we can use is a catheter that is placed percutaneously through the internal jugular and directly into the coronary sinus, also under TEE guidance. At the end of the procedure, we will use ventricular pacing, right ventricular pacing. This is usually performed on the arrested heart just to facilitate placement. We use bipolar right ventricular pacing wires typically for these cases. The wires are then brought up through one of the chest incisions and secured to the skin. Atrial wires can be placed if necessary, but that would be very difficult, very challenging. So routinely, we've only been using V wires for these cases, at least in my service. And the use of intraoperative TEE, well, it's pretty standard in cardiac surgery these days, as you know.
Dr. Josh Reisman has joined the meeting.
But for mixed cases, TEE is even more important. It's really essential for a number of reasons. Some of them I've already mentioned in this presentation.
Josh
TEE
Reisman
is
has left the
instrumental
meeting.
in reducing complications from peripheral cannulation, from injuries related to wires, to poor venous drainage, secondary to malposition of the cannulas. It informs us about the presence of aortic regurgitation, potential difficulties for myocardial protection, advises of any severe atherosclerotic disease involving the aorta, guides endoballoon positioning when that's necessary. But to me, one of the most important uses, one of the most important reasons why TEE is so essential, it's for the assessment of right ventricular function. All of us are very used to looking over the drape and being able to actually see
to
the
everyone.
right ventricle.
Announcements during the talk may please be muted.
Right
Thank you.
ventricular function during the conventional sternotomy. Mix steals this ability from us. So the small incisions and the limited exposure of the heart really prevents us from looking at the right ventricle. So the TEE becomes really pivotal in these cases. And last, definitely not least, is the problem of postoperative pain control, which is created when we switch from a sternotomy to a much more painful incision, which is the thoracotomy. We should not underestimate the importance of this. All the benefits of mix in terms of fast recovery, fast rehabilitation, fast discharge from hospital can be significantly offset by the presence of inadequate pain control. There are a number of strategies we can combine to minimize postoperative pain. Everything the surgeons can do to minimize chest wall trauma will be helpful in these cases. Things like limiting the size of the incision, minimizing the degree of retraction, and avoid rib spreading can be really helpful. They will use smaller size chest tubes, softer drains instead of the standard chest tubes that can cause a lot of compression and irritation of the intercostal nerves. And regional anesthesia can be really helpful here, from a simple intercostal nerve block to different types of ultrasound guided blocks, such as the ESP, the SAP. All of this can be really helpful to improve pain control and minimize the use of systemic opioids. Unfortunately, a discussion of the pros and cons of each one of these techniques is beyond the scope of my presentation. We don't have time for this today, but what I'll tell you is that the choice of technique is largely influenced by institutional practices and individual practitioners' expertise with each one of these techniques, way more than any evidence or data. And more recently, there's this new technique that's becoming increasingly popular amongst our surgeons, the cryoablation of intercostal nerves. The surgeons will use a disposable probe, which is inserted through one of the chest incisions to actually freeze the intercostal nerves on multiple levels above and below the main chest wall incision. This technique is known as cryoneurolysis. And essentially what this probe does is it induces a specific type of nerve injury called Wallerian degeneration, in which the axons are destroyed, but the structure of the nerve, so to speak, is preserved. So we hope that the nerve will regenerate, regrow, and regain normal function. This may take anywhere between a couple of weeks to months. In the meantime, that area innervated by the nerves that were frozen remains numb, and that's where the benefit of analgesia comes from. The main risk here is to create chronic neuropathic pain. We know that's always a risk. Whenever we cause an injury to a nerve, neuropathic pain can develop. Cryoneurolysis is not a new concept. It has been abandoned for a reason, but it's making a huge comeback. Now, maybe it's the new technology, the new probes, the new technique make it safer. We're starting to see the results of it. The literature is growing. We have already some small RCTs, not just in cardiac, but also after mastectomies, thoracotomies. The preliminary results are promising. We'll see what the future brings. I remain cautiously optimistic about this. So in summary, the appropriate selection of patients is a key aspect to reduce complications from mix. There are multiple aspects of the procedure which impact perioperative management. One lung ventilation is an important consideration. It's really what makes these cases challenging for us, and it can be high risk and very poorly tolerated by some of these patients. TE is essential, period. Multimodal analgesia to optimize postoperative pain is crucial for enhanced recovery. Thank you all very much.
Thank you, Camila, for that nice talk. I will now open the session for the questions, and I will take questions one by one from the chat box. And every one of you, thanks for your time and devotion and presenting these all things. So I will start with the Scott. You are the main target of the questions today, because I think you really presented new aspects of the diastology to the audience. So the first question, which I can see, which is directed to you, is what is diastolic stress test? How do you perform it in Ecolab? And actually, this was coming to my mind also. Can we do this diastolic stress test in perioperatively also, like in the OR, or it is only reserved for the Ecolab?
First of all, I'd like to apologize for the noise you may hear in the background. We're constructing a new emergency room, and unfortunately, a lot of the jackhammers are going outside my window, so I'll try and speak a little loudly to get over that. But thank you for that question. As I mentioned in the talk, some of the patients that we see do not manifest symptoms at rest, but we highly suspect that they may have diastolic dysfunction, and a certain proportion of the population, once stressed, develops symptoms. So the ways that you can do this are either with a supine bike or with a treadmill. So you would exercise the patient, and then you would lay them back down in the case of a treadmill, and you measure the mitral inflow patterns to calculate an E to E prime, and also measure the TR velocity. So those may then increase in that population to give you the diagnosis of diastolic dysfunction in that setting. Initially, when patients exercise, obviously they become tachycardic, so you may get E to A fusion, but during the recovery time, post-exercise, that usually separates and you can still make the measurement. So we find it very, very helpful in certain patient populations. Virendra, I think it would be difficult in the operating room because things like dobutamine haven't been recommended to be used. So I think it would be difficult in that circumstance to do a stress test.
Thank you, Scott. So next question coming is for Dr. Kathirvel. Kathirvel, the question is, why is fresh whole blood not supplied in most of the blood banks nowadays?
So that's really an interesting question that needs to be further explored. But I can tell you the most experience with the fresh blood is in massive transfusions in trauma patients. So you can use, that is a specific use, you can use fresh whole blood for those patients. But in patients undergoing cardiac surgery, you can categorize whether these patients require RBC or whether they require platelets or they require coagulation factors. So it's easily a component transfusion is really easier in patients undergoing cardiac surgery. But again, can you give whole blood? What is the disadvantage of giving whole blood? Number one, you have to preserve this whole blood. And number two, you have to refrigerate. If you refrigerate, the efficacy of platelets will go down, number one. If you store for a long time, there is always a storage solutions required to store this blood that may dilute the coagulation factors, that may increase the infection risk. So those are all the risks involved in. So the basically two factors involved in cardiac surgery. Number one, preservation of these blood products. Number two, refrigeration. Then can you remove the leukocytes and platelets and then transfuse? Removing leukocyte is a practice commonly applied, but if you remove leukocytes, platelets also will be removed. So that could be a problem too. So those are all the considerations. But to be frank, there is no randomized clinical trial in cardiac surgery specifically saying that whole blood should not be given. If you have a freshly, taken fresh whole blood, yes, it can be transfused. But if it is a stored refrigerated blood, the efficacy can be reduced, and that may not be an ideal solution in cardiac surgery.
Yeah, thank you very much for that answer. And Kathir, in our setup we have Jonah. Actually, he's one of our faculty members who has the special interest in the hematology. And the same question I was discussing with him, like, Jonah, what's the reason? Like nowadays we don't use much of the this whole blood. So his answer was that because now our understanding of the transfusion has improved and we know like what component needs to be given in a particular situation. So we might be over transfusing, like we might be over transfusing the factors which are not needed for that patient, and they can be given to the other patient. And at the same time, the shelf life of whole blood is less than the components when they are separated from the blood which you already cover. So I think that is the reason, because our understanding has matured in the transfusion therapy, and that's one of the reasons that for the resource, from the resource point of view and the economics point of view and longevity point of view, we are shifting away from this whole blood therapy. But yes, in trauma, it still has the use.
Yeah.
Dr. Machado, now, Camila, this is a question for you. The question is, like you talked about the Harlequin syndrome and the shunt fraction during the single lung ventilation. So the question was like, why can't we use PEEP or CPAP like we do in the thoracic surgery in the minimal invasive surgery also? And at the same time, the question was also added to this was that how you decide whether you will use a bronchial blocker or the double lumen tube in your minimal invasive surgeries?
Well, these are tough questions. I think we didn't have time to discuss the management of hypoxemia in one lung ventilation, which is definitely a very important consideration here. That would render a whole presentation for sure. Yes, when hypoxemia develops, I think you have to follow, there's a certain sequence of steps you can follow to try and manage that before going back into two lungs, which is ultimately the treatment for it, right? So confirming that whatever device you're using for isolation is well positioned. A lot of times hypoxemia develops because you are too deep in the dependent lung you're ventilating and you're isolating one of the other lobes. That's one common cause of hypoxemia these days. Malpositioning of whatever device you're using. Typically, this would happen with a double lumen. And then there are interventions you can use on both lungs to treat hypoxemia. You can do apneic oxygenation or CPAP in the non-dependent lung. That can be problematic because the lung will inflate, and that can compromise the surgical view. So the surgeons may not be able to work with that. So we leave that as a last resource. The most obvious thing to do is to optimize your ventilation to the dependent lung. You basically have to minimize as best as you can shunt in the dependent lung. So treat atelectasis by optimizing your ventilation, recruitment maneuvers, adjusting PEEP, and adjusting your FiO2 to see if that is enough to treat hypoxemia. Traditional teaching has always been that you have to be careful with a PEEP in the dependent lung, because if you use too much PEEP, you will increase PVR and end up diverting blood to the non-dependent lung, and that therefore worsening hypoxemia. In clinical practice, this is one of those dogmas, right? We have in anesthesia. There's really no good evidence for that. And we don't know how much PEEP is safe or enough. It's totally fine to increase PEEP in the dependent lung as long as you are monitoring for complications from it. Auto PEEP if you have patients with obstructive lung disease. And obviously, if you're increasing PEEP and oxygenation is worsening, then maybe you're at that level where you're actually increasing intrapulmonary shunt to the non-dependent lung. So those are the things I would do first. And then you can use CPAP in the non-dependent lung. You may have to work with the surgeon, and the limitation here really is surgical exposure.
Okay, Scott. So you're
Sorry.
okay. I'll come back again to you. So Scott, this is a question, very interesting question for you. How the diastology is affected by the anesthetic agents?
Yeah.
And the second part is like, if you do it perioperatively, how it will alter your decision making during separation of the pump, or during that time when you are coming off pump, or how does it make any difference, or it is just like that?
Yeah, I think, you know, Virendra, the guidelines haven't really been validated in the operating room, I think, for obvious reasons. And in the cases where it's most important, it's usually the bigger cases that we're doing, cardiac cases, big abdominal cases, vascular cases where there's fluid shifts. And the operating room is really a challenging place to assess diastolic function because of rapidly changing hemodynamics. We have rapidly changing fluid status in these patients. They're often on vasopressors or inotropes. And the other thing is, you know, from a transesophageal approach, we all know that it's very difficult to measure all the parameters in the guidelines. Like left atrial size is a challenge by transesophageal echocardiography. There's really no good way of measuring it. I think intuitively, we know that when we perform an examination, we can tell if the left atrium is big. If we easily fall into the left atrial appendage, we know it's enlarged. I often look at the preoperative report to see what the size of the left atrium is before the patient gets to the operating room. The other thing is TR velocity can still be difficult to measure in the operating room as well. You know, unlike the transthoracic approach where you can manipulate your probe a little bit to try and isolate that flow, it's still difficult in the operating room to do that. In terms of the intraoperative management and what do I do? Well, firstly, I'd like to say that if you have a patient with diastolic function who's coming to the OR, it's really important to make sure they have controlled blood pressure before the procedure. And certainly in the procedure, intraoperatively, you want to manage their blood pressure carefully, particularly that population with grade 2 or grade 3 diastolic dysfunction. Fluid management becomes absolutely critical in these patients because, as we know, a very small amount of fluid could tip somebody into pulmonary edema who's at the grade 2 to grade 3 stage of diastolic dysfunction. I'm very aware of tachyarrhythmias because they can be a big problem in the operating room, and certainly atrial fibrillation in our patients with diastolic dysfunction who rely on that atrial kick and lose it. And in the operating room, I wouldn't hesitate to cardio some of these patients out of atrial fibrillation to try and restore a normal sinus rhythm. And ischemia can also be a problem, creating more diastolic dysfunction because of new wall motion abnormalities and flow. So I think all of these things make it challenging in the operating room. I'm certainly cognizant of all my patients with diastolic dysfunction, but both measuring it and treating it is challenging.
Yeah, thank you, Scott. And just to add upon this, one of the important things which I have found is that if I am aware about the diastology, I will ask the surgeon, I will insist upon the surgeon that he must put the atrial pacing wires. Because
Absolutely.
many times, like just atrial pacing makes a lot of difference in your inotropic requirement. Like you might be unnecessarily using, or struggling with the hemodynamics, and whereas it is just the diastology and just the atrial kick which is required for the patient.
For sure. And
So,
Virendra, we do know also that our patients who come to the operating room with significant diastolic dysfunction have poor outcomes, for sure.
yes, absolutely. Yeah, thank you. So this is the question for now, Dr. Kathir. The question is, can you give an outline of your test and your component therapy, like when you have emergency situation, the patient has received just ticagrelor or some of these drugs, and now they suddenly come up from the cath lab to some emergency rescue surgery. So like what type of point of care testing do you do, and how you manage your blood component therapy in such patients?
So that's obviously a very difficult situation we come across. Whenever possible, first of all, we delay these cases unless it's a real emergency. So if you have a patient with ischemia, and if the patient can wait on heparin infusion, we delay these cases with Plavix for it to get out of the system. So it is a 3-day, 5-day, 7-day rule for different drugs. If you think Plavix is the common drugs used, we wait for 5 days. But if a patient is an inpatient and require an urgent CABG, we do P2 white well assay. If that assay shows negligible platelet function is there, so normally it may not take 5 days, because this is a lot of genetic mechanisms involved in these drug actions. So inter-individual variability for Plavix action is quite significant. So some patients may get rid of this platelet dysfunction within 2 days with the same Plavix level compared to other patients who may take 7 days. So I think objective evaluation of P2 white well assay is really important in urgent situations. I'm not saying if it is an elective situation, stop the Plavix, wait for 5 days, go for surgery. If it is an urgent situation, whether to go or not, then you do P2 white well assay. If that Plavix action is insignificant, then you go for surgery. If it is an emergency surgery, you have to crash on bypass from cath lab, that you can't help. You can only do platelet transfusion as much as possible to stop bleeding. There is no other way. You can give TDAVP. It may have a role in improving platelet function, but there is no other treatment available. Unfortunately, you have to give platelet transfusion. Do we do any special platelet function tests in the OR? No, we do not. So we just do TEG. We look at the maximum amplitude. So there are some newer equipments like Quantra can differentiate between fibrinogen defect or platelet defect, but we commonly use TEG, maximum amplitude. So the institutional monitoring of viscoelastic testing may tell you whether the platelet dysfunction or not. So we can monitor viscoelastic testing. No other special testing we use, but we have to use platelet transfusion as much as possible.
Thank you. We had some experience. We were having this platelet agitation aggregometry, which used to give us like dead platelet, like functional and the non-functional count, and then you used to subtract to know like how much are functional. But the results were very, very variable. Like sometimes they will like lead you crazy. So probably now we are not doing those tests, but there was a phase when we were doing those tests. So Camila, there is a question for you. Now, there is a learning curve in the minimal invasive surgery, and whenever these type of programs are started, complications do take place, and sometimes the complications are life-threatening in the minimal invasive surgery because the surgical access is limited and the surgeon cannot immediately go for the rescue things. The question is, have you ever faced such situations, and what are the difficulties of resuscitations in this type of situation and how you overcome that?
Well, yes, there's definitely a learning curve. And I think in our program, we're still on the steep part of this curve. It's a young program. And I have seen 2 cases of that had to be converted. One of them was converted emergently to a sternotomy, and that was a perforation. Both of them were related to the peripheral cannulation. So that's why I say that peripheral cannulation is a crucial part of this procedure, and we have to be very attentive to it. So we had a case of perforation of the right ventricle, and the other case was actually a perforation of the common iliac artery, leading to massive retroperitoneal bleed. So it's hard to, I think, give advice on that because, it depends on what kind of complication you're facing. Generally speaking, I think preparedness. Always make sure you have good monitoring, you have an art line that's well functioning, that you have good large bore venous access, that you have products available. We always start our cases with emergency blood, at least 4 units of blood available in the fridge. And, that's the best thing you can do. The manage of the complication itself largely depends on what complication you're dealing with. It's definitely challenging when injuries happen for the reasons I've already mentioned. Patient's heparinized, patient has limited physiologic reserve. A lot of times they have cardiovascular disease, they have pulmonary disease. They're heparinized and they may not be supine. So yes, it's definitely challenging to deal with the usual complications we see in cardiac in this situation. So my best advice is be prepared, anticipate as best as you can.
Yeah, thank you for that sharing the experience. So actually, unfortunately, Dr. Shivamurthy Shale from the Cleveland Clinic couldn't join us. He was busy, and the Cleveland Clinic is one of the very big center, and they do a lot of minimal invasive surgery, and I was just discussing with him some of the peculiar things. And I think one of the case we also had in Winnipeg, if the patient arrests during minimal invasive surgery, giving the shock becomes very, very difficult for giving the shock, and resuscitating becomes difficult because deflated lung does not transmit the electric energy. So sometimes you may have to inflate the lung, and then it may be competing with the surgeon, because surgeon at the same time want to do the CPR on the heart by putting the hand inside. So he may insist like, can you keep the lung deflated? And when he remove the lung, you may have to immediately inflate the lung, because in deflated lung, the shock doesn't go. And then the other thing which he was telling was like, the ECG positioning is also very important in these cases, because what happens is when the lung is deflated, your ECG pattern keeps on changing, because the whole transthoracic impedance changes. That I did not notice myself, but that was one of his observation, that this is another issue which basically takes place during these minimal invasive surgery. So Scott, I am going to give you these 2 questions together now. The first one is, what is the validity of old versus DDD classification in present time? And the second is, what is the role of mitral acceleration time, mitral deacceleration time in diastolic dysfunction? how is pseudo-normalization of LA pressure defined and its clinical significance? And the question says, like, this old and new, this diastology classification, some cardiologists still keep on giving the, the report based upon the older classification. Yeah. So what is the clinical significance of these?
Well, as I mentioned earlier, I think the reason that we moved from 2009 to 2016 was really to simplify things. And I think every echo lab should be using the 2016 guidelines now, because it really is much simpler to use. Things like color M mode flow propagation velocities and pulmonary vein flow is very difficult to do in many of the transthoracic patients. So I think, certainly many echo labs got frustrated with some of these measurements and found that it was just too challenging to do. So moving to the new guidelines definitely simplified things. When you compare the old versus the new, a number of the studies that I saw looking at patients, particularly with normal left ventricular systolic function, the new guidelines had significantly lower diagnosis of diastolic dysfunction than the 2009 guidelines did. I think it was something like change from 20% to about 10%, and these were 500 patients that they looked at in a row. But what happened was, using the new guidelines, we found out that we did increase our diagnosis of indeterminate, which is something that we want to try and avoid. And that was why I was trying to highlight the fact that, if you can't get your TR velocity, which is, again, typically the one that's going to be missing, try and use something to enhance that signal. And the other thing is, as I showed at the end of the slide, that left atrial strain may be able to replace that. Now, the authors have been working on the new guidelines as of now, so they've already started their meeting. So I'm anticipating that we see a new set of guidelines, probably somewhere in 2025, that even simplify things even more and try and make it a little bit easier for everyone to use and understand. With respect to deceleration time, I think, and pseudonormalization. So if you remember what grade 1 diastolic dysfunction looks like, you have an E to A ratio that is less than 1, so a small E wave and a big A wave. And this is the situation where the volume of blood that enters the left ventricle during the early filling phase tends to be a little bit less. So you have an increase in stiffness, little less blood goes through, your E wave is smaller, there's more blood left in the atrium at the time of atrial contraction, so your A wave rises. As you progress to grade 2, which is called pseudonormalization, because the E to A is greater than 1, and it almost looks like a normal pattern, but there are differences. So that phase of pseudonormalization is characterized by a further rise in mean left atrial pressure, and it really represents just a further reduction in LV compliance, so that you have basically a higher pressure and the E velocity then increases because of that higher left atrial pressure. And the difference between normal and pseudo-normal is the deceleration time, because if you look at the deceleration time on your E wave in normal patients, it's probably around 240. Whereas in pseudo-normalization, it's in the range of 150 to 200. So you get a more rapid drop of your E wave, indicating you have elevated filling pressure. And it's helpful, again, as I mentioned, in those patients with atrial fibrillation, where it has been validated that in patients who have atrial fibrillation and impaired ventricular function, if your E wave decelerates rapidly at 160 meters per second, then that can correlate very well with elevated left atrial pressure.
Thank you, Scott, for clarifying. I think that was a very clear answer on that question. So, Kathir, here is a question for you. So, now, how much importance do you pay to the hemoglobin level when there is a perioperative bleeding issue, and to the fibrinogen level? Like, the question is, do you follow some target of fibrinogen level when the patient is bleeding, like deep hypothermic arrest or trunk procedures or hemi-arch replacement? And these patients, do you try to target some fibrinogen level? And do you still stick to the low 75 hemoglobin or 80 hemoglobin in these patients, or you try to keep the hemoglobin level high in this type of patients?
Yeah, so that's a good question. Coming to the fibrinogen, it is better to be prophylactic rather than reactive. So what at our institution, when we come off rewarming, when the temperature reaches 28 to 30, we send a full coagulation profile, which will basically look at platelet count, fibrinogen, PT, PTT, INR, everything. Though PT, INR, and PTT may not say a lot because the patient is heparinized, fibrinogen levels will tell you whether the patient is going to need cryoprecipitate or fibrinogen concentrate. So we do that prophylactically. So we are prepared at the time of coming off bypass and giving protamine, we are ready to administer cryoprecipitate. The problem with cryoprecipitate is once you order blood bank and it comes to the operating room, you can't return back. That is a problem. So we are very cautious in ordering cryoprecipitate for these patients. So once we usually give 2 bags of cryoprecipitate, which has 10 units of 10 pooled units. Then we repeat the fibrinogen levels. That's what typically we do. But the several institutions also use point of care coagulation testing instead of fibrinogen levels. So you can say if you have a ROTEM monitoring, you can send FIPTEM when you are rewarming with heparinase option. Then if the maximum clot firmness is less than 20, then you suspect the patient is having fibrinogen deficiency. Then you prepare for cryoprecipitate. So you can use either ROTEM, or you can use plasma fibrinogen levels. It is better to be prophylactic than wait till you come off bypass. I think it's a common cause of postoperative bleeding, fibrinogen deficiency, and it is as common as, if at all, slightly less than platelet dysfunction, but it's very common, especially after deep hypothermic circulatory arrest.
Thank you. Camila, this is the last question for you. So I think we missed that answer. So how you prefer, whether you should use bronchial blocker or double lumen tube? Because the Cleveland Clinic, I was talking to Shivamurthy Sale, they started with bronchial blocker, but now they have totally shifted to the double lumen tube for the minimal invasive surgery.
So I think ultimately you have to do what you're comfortable with. Whatever you have expertise is likely the safest thing for the patient. I use bronchial blockers for all my minimal invasive cases. I've never had any problems. I think the main advantage is that you don't have to replace the tube at the end. And I can't say I have experienced difficulties with lung isolation. But I do recognize that if you are not familiar with bronchoscopy, and if you're not performing lung isolation regularly in your practice, it might be easier to start with a double lumen tube. It's really a matter, I think, of personal level of comfort. Yeah.
Thank you. So just to summarize all, I am first of all very thankful to Dr. MacKenzie, Dr. Subramaniam, and Dr. Machado for their excellent presentation, for their time, and presenting on this platform. Scott, you had made the things very crisp clear, and I think the take-home message from Scott talk is that diastolic is important. It cannot be ignored, and even in the perioperative period, it is important. And knowing that the diastolic is impaired, it alters your management plan. And now there are some criteria which are very straightforward, where you can actually anticipate in those situations where it was said that diastolic cannot be measured, like in atrial fibrillation, like the L wave, looking for the L wave in the atrial fibrillation, or looking for the IVRT time in cases of the mitral regurgitation patients. So I think those 2 points are important, that diastology is important for the perioperative period also. Dr. Kathirvel I think he clarified all aspects of the things, but I will like to share our Winnipeg experience also. I think in the management of this perioperative coagulopathy, first important thing is the surgical skill. Subramaniam also knows, he worked with me in PGH Chandigarh. I also worked there for 22 years. Then we moved to the Winnipeg, and here also I have been working for now more than 10 years. I have seen the phases of transformation of the surgeons in Winnipeg as well as in India also. When the surgeon is trained, or when his level of expertise grows, what one of the surgeons used to say, barter tight sutures. Like some of the surgeons which were doing the pediatric surgeries, neonatal surgeries, like I have seen them doing the dissection also. Like they put the sutures such barter tight that you can see that now the bleeding is only like medical bleeding, and you have to manage the medical bleeding also. But at the same time, some of the surgeons, as their skill is growing, sometimes they try to rely for surgical bleeding also by overdoing the medical stuff, like the blood component and all those. So that is, I think the surgical skill is one of the important things. The second thing which I have noticed in my practice is, and you are open to share your comments on that, that when you encounter or a patient who is likely to bleed, like a patient with cirrhosis, you know, this patient is likely to bleed, a patient with end-stage renal failure, where you anticipate certain dysfunction, or you are doing deep hypothermic arrest, they're lagging behind in management of coagulopathy sometimes leads you into a vicious cycle of blood products, bleeding, blood products, because all the blood products, they don't reach immediately when you need. They sometimes take some time. And if you are lacking behind, then you enter into a vicious cycle. So I think that anticipation is very, very important, apart from the point of care testing. And the third thing is, I have seen my colleagues who were actually part of the trials, which actually recommended these guidelines in the Canadian system, that you can manage the patient non-inferiority trial, like you can manage the patient with low hemoglobin level. I have seen them also working with these situations when this type of bleeding patient they encountered, they never kept their hemoglobin less than 100. Like they were keeping the hemoglobin also high in those patients. So I think when we are working in the practical, pragmatic world, the hemoglobin is also a very important thing, because in the bleeding patient, you cannot just keep targeting the 70 and think that everything will, like the patient with bad function and all those. So probably a little bit liberal or little bit liberal attitude, you have to decide patient to patient basis. And I think minimal invasive surgery, this is a very good skill. And I think the outcome, fast tracking, it has changed with that. And I think the cryo has come back because now we have more control about the temperature and timing. Previous study in the 70s, 80s, when it was used, actually the temperature, I think the people were not that temperature sensitive and time sensitive in application of the cryo. And I think now the newer generation of these cryo machine, they have more precision about the how much temperature has to be applied to the nerve and for how long it has to be applied. And probably they are anticipating that probably this long-term complications or pain syndrome with cryo may decline with that. With that, I thank you all, and I invite now.
Before I thank everybody, just to give a few comments for this webinar. Of course, it was an excellent webinar, needless to say. And the topics that have been chosen by Dr. Virendra Arya are, of course, pertinent to cardiac anesthesia, but also to the general anesthesiologist. So they were very well chosen. Dr. MacKenzie, when he talked about the diastolic dysfunction, I remember a couple of years ago, none of us really realized the importance of this. And gradually we realized that how important it is. And Dr. Subramaniam, the coagulopathy, yes, we in our practice also, we in our hospital are using TEG. We are very fond of TEG. And we are very comfortable with this, and it's doing the purpose. And Dr. Camila, thank you very much for the topic. and of course the minimally invasive cardiac surgery, but also the points were so helpful to us in thoracic surgery that we do very often in our hospital, and so well said about the bronchial blockers and the double lumen tubes. And it was very interesting to know that how cryoablation is now back in the armamentarium of the pain physician. Dr. Virendra, thank you so much. And thank you so much, Dr. MacKenzie, Dr. Subramaniam, and Dr. Camila. And we look forward to having such wonderful webinars in the future. Thank you so much for sparing your time. Thanks a lot and good night. Thank you, Abhijit, for being there, Dr. Radhakrishnan and Sanish. Thanks a lot. Good night. Have a good day. Have a good day.
Good night.
Thank you. Thank you very much.
Bye. Bye.
Thank you, Virendra. Thank you.
Thank you. Thank you,
Thank
Scott.